welcome to this week's or this month's edition of Building Your Defense. This is an expert speaker series where we bring in leading experts in the field uh, to show not just how you can poke holes in a plaintiff's case, but rather how you can hire the right experts to help build your defense. I'm here today with Blaise Zach. My name is Gregor Allen, and we are associates at Brownlee LLP's Insurance Group. Also here today, and we're pleased to have Dr. Shawnda Lanting, who will be speaking about how litigators and neuropsychologists work together to address neuropsychological and litigation issues with brain injuries, focusing on concussions. And so Dr. Lanting completed her postdoctoral fellowship at the University of British Columbia in 2013 and has been qualified to testify as an expert witness in neuropsychology in British Columbia. She works as a neuropsychology consultant for Telus Health. And to share some exciting news, she recently moved from Vancouver to Edmonton. It's not Calgary, but we all make mistakes. That's okay. I grew up there. Why do you think I live in Calgary? So now she works with Viewpoint Edmonton, Viewpoint Calgary, and Viewpoint Vancouver. Speaking of Viewpoint, this series is sponsored by Viewpoint Medical, Invista Forensics, and Westbridge Ventures. And so we thank our partners and help bring this together. Dr. Lanting, thank you for joining us.
Thank you for having me. I'm excited to be here today.
So why don't you tell us a bit about yourself? Give us a bit of background on kind of work you do beyond just beyond academic credentials, and help us kick this off.
Yeah, so I'm a registered psychologist with specialty in neuropsychology, and I can explain what exactly that means. So I have a PhD, and then I specialize with a 1-year residency and a 2-year fellowship in the area of neuropsychology. My initial background and training was in neurodegenerative disorders and better detection of dementia in the early stages. But over time, I had more practicum and residency experience in traumatic brain injury and in medical legal evaluations. I was lucky enough to have supervisors that practice in that area. So since I've registered, I've practiced in neuropsychology in a wide variety of referral questions that need to be answered, but typically most recently in disability and med legal settings.
I gotta ask a burning question. How long did it take to get that many letters after your name?
Okay, yeah. I would say after grade 12, about 12 more years after that. So I'm starting from kindergarten again. And I think there are some folks that do it sooner, but in the US, the gold standard is to have that amount of training in order to board certify. In Canada, there's less regulation, but we try and maintain the highest standard.
I can only imagine. Jeez. Blaise, what are your thoughts?
Well, I'm really interested in the area of mild traumatic brain injury. I would bet good money on the fact that there's probably not a personal injury defense lawyer in Alberta that doesn't have a case where there's an allegation by a plaintiff of a concussion. So if it's all right with you, I would be hoping to start with getting some insight into concussions. Then we can talk about neurological assessments, and then maybe we can hear about a case study showing how your services can be used to help build a defense. Is that all right with you?
Yeah.
Okay. So, as defense counsel, we get plaintiff medical records, which can often contain concussion diagnoses from chiropractors, physiotherapists, psychologists. And these reports, there's often vague statements about headaches, dizziness, and nausea. And then there's some other red flags that can be difficult for non-experts to disentangle here. Say there's no report of loss of consciousness or a head impact, but or maybe references to like pre-existing conditions that seem related, like migraines or something like that. So given your expertise, could you tell us a little bit about what a concussion is?
Yeah, that's one of the most challenging areas of this work is and what is a concussion and what qualifies? And various clinicians understand it differently, but the most commonly accepted diagnostic criteria based on massive consensus groups are that it's a diagnosis made at the time of the injury. So you want as close to contemporaneous records as you can. Often in mild traumatic brain injuries, you're relying on self-support because there may or may not be emergency medical services at the scene. There may or may not be a hospitalization within the 12 to 48 hours after a concussion. So we generally define concussion as there has to be enough of a mechanical force applied to the brain, and that can be direct force, that can be like an acceleration, deceleration injury, rotational injury, blast force. And there is some just kind of discrepancy on what is the minimum biomechanical threshold to produce a concussion. So that is still not determined, and I defer to accident experts to comment on that. But you can have, if you have enough of a force, then you have a few criteria. You can have one or more. One is loss of consciousness. But in most cases with a mild traumatic brain injury, there is no loss of consciousness. So then you're looking at, was there clear evidence of a mental status alteration? So disorientation, confusion, feeling really out of it. And that can happen too with the psychological reaction to an injury. So you want to be really careful in understanding that set of symptoms right after concussion. And then post-traumatic amnesia, which is, do they have some discontinuous memory for, it can go from before the impact, including the impact, and then after the impact as well. And for a mild traumatic brain injury, that's usually less than 24 hours of post-traumatic amnesia. You can have focal neurological deficits as well. Don't have to. And then we define mild traumatic brain injury as complicated when there's a skull fracture, there's intracranial findings, and that is important because the outcome is often more complementary or consistent with a moderate traumatic brain injury.
Sure, that makes sense. And so now that we have kind of a sense of that, let's maybe turn our attention a little bit more to like the litigation context. So, I'm getting these records. There's, the chiropractors of the world gives me concussion diagnoses, and then I have a plaintiff in it questioning, and then they're like, I feel like a lot of these issues are cervical in origin, or just something that just seems like that seems a bit different than the concussion claim that's being alleged. And so, are there any other like related diagnoses that we might be on the lookout for here, where there's claims to concussion?
Yeah, oftentimes there's a wealth of research showing that a WAD injury, so whiplash injury, can produce a lot of the same symptoms as a concussion, but there is no concussion. It's related to the whiplash injury. You can get also symptoms that look like concussion after the fact. So fatigue, dizziness, cognitive fog, nausea, kind of they're non-specific symptoms basically. And they can see a whole other controversial topic of post-concussion syndrome, which a lot of those diagnoses are made a few weeks to months after the injury when they're having these persistent symptoms. But it's really about sleuthing and looking to see, okay, well, were there characteristics, injury characteristics, time of the injury? And then we also know depression, orthopedic injuries, just general bodily pain, whiplash injuries, vestibular and visual symptom or oculomotor injuries can also produce symptoms that would meet criteria for post-concussion syndrome.
This is getting we're going to keep on building the complexity to argue why sometimes we do need you, but there are some cases where it just the claim to a concussion just seems incredible. I'm thinking of low speed collisions, some sideswipe collisions, impacts where there's no where there's no head impact, and so. Is there anything that would make someone uniquely vulnerable to a concussion, the glass skulls of the world, if you will?
Yeah, and neuropsychologists are somewhat unique in looking at the complexity of this issue and breaking it down to pre-injury, peri-injury, so at the time of injury, and then post-injury factors that can influence how someone presents and their symptom presentation after concussion and their recovery trajectory as well. So, as you know, most concussion also known as mild traumatic brain injury. Those terms are used interchangeably. Most concussions recover in the athletes, so sport concussion research and general research on concussions. They usually clear within a few weeks to months. And so when there's persistent symptoms, usually there's something afoot, and there's other explanations or other factors. But with people that are uniquely vulnerable, there's a few risk factors. One is catastrophic. I can never say that. They have a catastrophic reaction to the injury. They think they're very worried about the effects of their injury when they're not recovering as quickly as they think that they should. They often feel like they're now permanently disabled. There's often other cognitive biases or behavioral responses like diagnoses threat. So there's a group of researchers led by Julie Sir that looked at whether or not you influence someone by saying, we're going to do neuropsychological testing. It's to see if there's any effects of a remote brain injury. Here we go. When they compared to a control group, people that were expecting that they might do more poorly actually did do more poorly. So there's that kind of expectation effect or nocebo effect when the expectation of illness actually makes you feel worse or makes you take on those symptoms. And then there's other coping factors, so avoidance, going into a dark room for too long, being very scared of being re-injured, being scared of pain. All of those factors can influence not only how fast you recover, but actually how entrenched your symptoms might become and worsen over time.
I think that you kind of anticipated a little bit where I was going with this, but I feel like there was two things that I wanted to just tease out of your answer there. So the first thing is just about treatment. As a defense counsel, I'm acutely aware that plaintiffs have a duty to mitigate their damages. They have to treat. And then I'm also on the lookout for things that might be exacerbating their symptoms. And so maybe could you tell me a little bit about what plaintiffs can do to treat their symptoms effectively, and then what steps they can take to make their symptoms worse?
Yeah, so again, you've probably seen these files where someone keeps presenting it to the family physician. They're very focused on their physical symptoms. Psychological treatment or even occupational therapy is not necessarily early in the process of intervention and investigation, but oftentimes early education around concussion. Looking at a file to see, is there even evidence of concussion? Because people can start to have the belief that they've had a concussion when in fact they might not have, and then start to act as if they've had a concussion and develop beliefs like, I'm brain damaged, my brain is not healing, I'm still affected, and that's actually unhelpful, and it'll kind of reinforce some of those symptom beliefs. So early education seems to have a very positive impact on the trajectory of symptoms, accessing evidence-based psychological treatment. So sometimes, in some cases, clinicians can be causing iatrogenesis, or they can actually cause the symptoms to be worse. We want to look at addressing the symptoms, coping, but also returning to function as quickly as possible. So I'm focusing on that.
So
Speaking of returning to function, it's one of the key issues we deal with so often is sort of the lingering of symptoms, right? And I find that particularly tricky in the context of how self-reported these sort of diagnoses are, certainly on an ongoing basis. Sort of with that in mind, what exactly is a neuropsychological assessment? And, what are the sort of primary purposes that you'd use it for in the context of insurance litigation?
Yeah, it's we're one of the fewer professions that look at formal validity testing. So again, one of the biggest challenges is that this is a diagnosis and the symptoms are usually based on self-report. There's no kind of single biomarker or kind of significant objective test findings. And so with a neuropsychological assessment, you're actually objectively measuring cognition. And that objective measurement can actually either match the subjective report or be quite discrepant from the subjective report. So it's another check into the symptoms that someone's reporting. What are we seeing objectively relative to a large peer group and what we'd expect for a healthy individual? And then what might be some of the reasons why there's a discrepancy between subjective report and objective test findings. And that gets into the question of malingering. So what is causing this discrepancy? And so with neuropsychological assessment, we're measuring higher brain function. So we look at domains like attention, processing speed, spatial abilities, expressive language, learning and memory, executive functioning. And then we're usually stratifying or understanding test results in the context of what we'd expect. So premorbid functioning, intellectual abilities, background. And then we're looking to see what those test scores look like. But one of the most important components is doing what we call performance validity testing or effort testing. And that looks at, are these symptoms, are they producing a minimal amount of effort that's needed in order for us to interpret the testing? Is this a credible pattern of performance? And is there, in fact, in some cases, based on the data, there's an active attempt to misrepresent, exaggerate, or fabricate their symptoms. So we can usually detect that cognitively if we're doing it correctly and with evidence-based neuropsychological testing. And that means more than one effort test, usually across, it's not a static thing. We're doing these tests across sometimes 2 days of testing. So we want to make sure that we're assessing over time. We also look at symptom validity. So what is the credibility of their psychological symptom report? And also what is the credibility of their somatic symptom report? So are they reporting symptoms that are very rarely reported in credible medical conditions or neurological conditions, or is it consistent with what they're describing?
And sorry, just for my own edification, when you say somatic symptoms, can you give me a brief explanation of what that means?
Yeah, that's a general term. And again, my scope is not medical practice. So we're measuring this with just what are they self-reporting and looking at large groups of samples that are known malingerers or feigners or clinical samples, healthy folks. So we have empirical data to say that somatic symptoms, which include pain, headaches, gastrointestinal symptoms, malaise or fatigue, sleep disruption. It's kind of a general sense of how they're reporting their physical symptoms. That includes pain.
Thank you. And so I suppose when you're looking at a file or when you're approached with one of these matters, what sort of information do us as lawyers or working with our adjusters have to put together in order to help you do this sort of assessment? Because again, it just seems so varied and multi-level.
Yeah, the more the better usually, although we can see files that range from a few pages to 5,000. So we get what we get. What is most helpful usually is as again the contemporaneous records. So primary injury records, if available or if possible, or someone's report of their immediate symptoms after the injury as close to the accident as possible. So if they're reporting to their family physician or if there's any kind of documentation around that, because oftentimes neuropsychology gets involved a year more after the fact. And so that's sometimes people have been educated on what a concussion is or how to describe their symptoms, or sometimes they just don't remember too if it's been that long. So primary injury records. I was listening to the previous podcast with Tyler Argue on surveillance and private investigation, and that is very interesting. And we sometimes get that as neuropsychologists, evidence that behaviorally they're presenting in the world in ways that are not consistent with what they're reporting. And that's helpful because our test tools don't always, unless we have a preponderance of data, we're not always able to look at intention or cross-context behavior. We're looking at how they are behaving with us in the assessment, and then what we have for file review, and then any specialist data as well. So if they've seen a counselor and they're not getting better, their symptoms are getting more entrenched, they're presenting their family physician with the same. If there's any evidence of non-organic findings that are made by other qualified medical professionals, and that helps us to understand, is this person presenting credibly with their symptoms?
And so how do you gather this sort of information? How do you present it to the court?
Yeah, so some would say we take too long to do that, but a typical neuropsychological assessment means reviewing the file, conducting a clinical interview, so asking the examinee about their history, because pre-injury factors are very relevant, their experience of what happened, the injury and post-injury symptoms. So understanding that from their perspective, and that usually takes a few hours to do well. They're doing self-report questionnaires, they're doing the objective inventories that have symptom validity testing, and then we're usually doing, 5 to 7 hours of neuropsychological testing that look at different domains of functioning and across time. And in cases where we have an available collateral interview. And the testing that we use, there's a lot of heterogeneity in neuropsychological assessment, but good neuropsych assessments have evidence-based tools. They're using large conorm batteries, so that we're reducing our risk of error. So if we're using a bunch of tests over 2 days, we can get a lot of false positives. So we get a low score, and we think, oh, there's something, but that can be kind of like reading tea leaves if we're not doing it in an evidence-based way. And so you're looking to see across large conormed batteries where there's less risk of error, how are they performing, and what are the base rates of those scores in healthy folks just generally. And then is this discrepant from that? And then the evidence-based tests meet the standard for admissibility in courts.
That comes together as a report, I take it.
Yes.
Or you're taking the stand.
Yes, yeah. So we're usually asked to produce a report and then provide evidence if asked to.
Yeah. I mean, that, I suppose that takes me to, I understand you have a case study for us today, a sort of John Smith anonymized example of how this all worked. I'm hoping if you can walk us through the Mr. Smith case study and help us understand a bit more how this works in the context of an actual example.
Yeah, and I'm guessing a lot of aspects of this case might be familiar to, and again, the presentation might be familiar to a lot of files that you've come across or reviewed. So it's John Smith is a 35-year-old male, was rear-ended. I'm asked to assess by the defense counsel, I think 4 years post-accident. They've had an assessment by plaintiff neuropsych and a vocational assessor, a vocational psychologist. They're presenting as being highly impaired. They're struggling to have returned to any kind of work capacity. So they're working in a very extranumerary capacity. They're saying that they're debilitated by pain, headaches. They've got cognitive fog, which impacts all of their areas of life. And their accident-related physical symptoms have caused them to feel depressed and anxious. And they claim that the accident has produced symptoms of post-traumatic stress. And so after understanding their self-report, they passed validity testing with the plaintiff neuropsych, but in that case, there was only one effort measure administered over a large, 5 to 7 hour battery. And so that's already a flag in terms of, okay, the methodology may have not been sound enough to have detected insufficient or even variable effort on the neuropsychological assessment. In the case of effort testing in the assessment I did, they failed all 3 effort measures, which were administered throughout testing, and several embedded measures as well. So based on those results, I conclude that we cannot validly interpret the assessment. In cases where effort testing, there are some effort measures that are forced choice. So they're based on binomial probability theory. And so if you have a score that's below chance, the idea is that you would have to know the correct answer in order to produce the incorrect answer. So there's some idea that not only is this insufficient effort, but someone is misrepresenting their cognitive abilities. And especially if that's consistent and there's other implausible areas of cognitive scores across their profile. So in this case,
sorry, not to interrupt, how do you catch that? When we're talking these embedded sort of choices in your own evaluations, how do you create that or catch that?
yeah, so there are standalone tests, so tests that assess just is this person giving their minimal amount of effort on a performance on a test? Are they engaged? Are they putting forth adequate effort? So those tests are people with severe intellectual disabilities that have severe brain injuries or advanced forms of dementia pass these tests. So there's generally no reason other than they weren't producing effort to have gotten a score in that range. So they're actual measures that we use that have that purpose. And then there's embedded measures. So there's measures that have research that they're part of a clinical assessment, but there's data that show if you get a score lower than this, it doesn't fit a known neurocognitive profile of dysfunction. There's very few explanations for it other than this is not credible.
So are these like multiple choice tests? Are they written tests? Are they like performance tests, like putting different shapes on different platforms or whatever? What kind of tests are we talking about here?
You sound like someone who's familiar with what neuropsych testing is.
Maybe, I don't know.
Done some fun with block testing before.
Sounds like me without coffee.
Yeah. Depending on the day, I'm not sure how I would do on some of these neuropsych tests, but yeah, the effort tests, there are a range. And so a good evidence-based assessment will use a range. And so there are some we call memory effort tests so that they look like they're measuring memory, but they're actually not. But the face validity would be someone thinks their memory is being assessed. There are non-measuring memory measures as well. So that look at perceptual or visual spatial or attentional like type tests, but again, they're effort tests. So some of them are computer based, some of them are based on whether or not here's something to look at. Can you remember after delay? You get a choice of things to look at, or a choice of two. And so they're various modalities, and they're meant to be. We let people know we're measuring whether they're producing effort, and sometimes we have to remind people to produce their best effort. But these are tests that wouldn't be they would look like any other measure.
So one way of measuring this relative effort is, like, I understand something about there could be the various levels of complexity in different tasks, for example, and so they'll be given a simple task versus a more complex task, and you can compare those two results.
Yeah, also, yeah. So yeah, there's, in addition to the standalone tests and the embedded tests, you're also, looking at their profile to see whether, and this is the case where with John Smith, it was interesting because sometimes they actually just get engaged in the testing. And so they, in this case, he performed very poorly on a simple task, and then actually had broadly normal performance on a more effortful, way more complex task, just because I think he kind of got caught up or engaged in the task. And so when you see that kind of pattern of performance, if someone's having non-credible performance on a very simple task, but yet their performance is much better on the more complex tasks, that is also another, again, you're looking at a whole bunch of data points, but that is another red flag.
So if I'm understanding what you're saying, there's these benchmarks you can compare, and then someone comes in, you can compare their performance against those benchmarks,
yes.
And then you have certain expectations about how they would perform based on like the record and document review, and perhaps you've been involved early in the process enough so that counsel can ask very targeted questions of them during questioning and that kind of thing, or get the right undertakings and so forth to be able to create your expectations about their performance, and then you look at their actual performance.
Yeah, and we have, not just our clinical knowledge about, intellectual background, educational background, any injury history before, neurodevelopmental conditions like intellectual disability, ADHD, those factor in. But mainly it's what do clinical samples, a general large group of clinical folks look like? What do healthy folks look like? And how much of a discrepancy is this performance?
Yeah, kind of linking back to like the how early are you involved? There's we talked about treatment, about how people can develop expectations about their symptoms, and then those like those self-perceived their perception of what a person's symptoms are, and how they're what meaning do those symptoms have? This must be a concussion. And so then if people are developing narratives about those expectations, you're able to tease out like the differences between a person's a lay person's understanding of what concussion is versus what these standardized tests are.
Yeah, I mean, generally we can, especially if someone's developed these expectations or this narrative that they're injured or they have cognitive problems, you can see that their subjective report is they've got cognitive problems, but their objective testing actually shows broadly normal performance, and they usually pass effort testing. And then you have some insight into understanding, okay, these are psychological factors most likely that are influencing their understanding of their illness and their behavioral coping. So that is one thing. And then if you can sometimes see people that are underperforming on testing because they're very, very they want to emphasize how impaired they are.
Mm.
Or how impaired they think they are, I should say.
And so in the case of John Smith, how did this end up affecting litigation?
Don't know actually. That's to be determined. I think there is a it's ongoing, I should say. And so it was used. The assessment that I did was at the time of mediation, so I don't know. It was fairly recent. What came out of that? So I think that the defense counsel was very pleased because it stacked up with other parts of the file that he'd reviewed, including questioning, and potentially, I think maybe there was surveillance data as well. But that's still
TBD.
TBD. Yeah.
To be determined.
Well, taking a step back, are there any other, we've talked a lot about concussions, but are there any other common insurance and litigation scenarios where these assessments are typically requested, whether it's a record review or an independent medical examination, and who usually requests them?
Yeah, I requests can be, so I do both plaintiff and defense evaluations, and I think it's helpful to often do both so that you watch your bias, so to speak, and that you're not developing any bad habits or patterns if you only see one type of case. And so I accept both referrals or disability referrals too for long-term, so employer requested evaluations or insurer requested evaluations, and sometimes family physicians if the question is they're not recovering from their concussion, is there anything else that you can add to the case? And so we usually the main referral question, or no, referral question, but the main type of case is whether this is a concussion or not, or whether concussion is part of their injuries, but also where the examinee is reporting both concussion and PTSD. So they're reporting a psychological and concussive injury, and it's sorting out is that credible? Do they have cognitive and psychological injury or neither? And in some cases, they're having cases where I've taken on, there's an assault or another type of injury, slip and fall injuries, where and some of them are very again, when you spoke about what is this is not a plausible mechanism of injury. If someone, you know, opens the door on someone and kind of smucks them in the head, that is not a plausible injury mechanism. But we see cases where that someone is bringing about a claim regarding some of these, or they slipped and, you know, fell and it felt like their brain got rattled as well. And in some cases there are injuries to that, and it's helpful just to sort out, okay, what's credible, what's corroborated, and then what do you do, how do you manage the file as well, and how do you look at whether the treatment that they have done has been evidence-based, or whether they've taken steps to mitigate their injury symptoms.
Excellent. We have a couple of more questions lined up for Dr. Lanting, but if anyone wants to put in their questions in the chat, we've got a little bit of time here, so and we invite you to put in your questions. So, like, I kind of zeroing in on, we talked a little bit about the expected length, but I'm not sure the expected length for a concussion, but how long will your average concussion, I know you last, I know you mentioned athletes last for a fairly short period of time, but, you know, in terms of what period does 90% of concussions resolve?
Yeah, based on the clinical research, and again, like caveats all over the place, because there's a lot of methodological issues in mild traumatic brain injury research. But based on our current data, where we're looking at heterogeneous samples, most folks, about 90%, do recover within about 3 months. Where they feel, and they may have other injuries where there's symptoms related to those injuries, but for kind of neuropsychological recovery, it's much quicker than that. But for people to report that they feel better or back to themselves, it's usually at the utmost around 3 months, sometimes more if there's a lot of modifying factors as well, like age, pre-injury history, and whether or not they had pre-injury history of migraines or multiple concussions. But for the most part, when we're looking at raw data, we're expecting folks to recover.
And then they have post-concussive syndrome, right?
And
what's wrong with that?
Well, I'm so glad you asked that. Well, the kind of word of the day is non-specific here. Again, it's a non-specific the diagnosis based on non-specific symptoms and factors. And so again, people with whiplash, depression, orthopedic injuries can criteria. And so it's, first of all, again, it leads to that narrative, PTSD. You can lead to that narrative: if I have post-concussive syndrome, then I have a brain injury or I'm not healing. And so also you treat the treatable. So there's a lot of symptoms that can be part of what is conceptualized as post-concussive syndrome. But if you start to treat those, then you see recovery. So it's really about looking at the symptoms and treating the treatable, and then seeing what's left over. I don't know if I answered that.
No.
I'm curious. So I thought you did, but I'm curious what sort of, because again, I have a file right now where I'm dealing with two intervening causes. It can be very hard to disentangle which fall off a horse versus a low speed rear ender within 2 weeks of each other, which caused the particular brain injury or alleged brain injury. But there's also a very long-standing history of mental illness, bipolar disorder, anxiety, depression, a very heavily medicated plaintiff for a number of years, who presented as manic within literally days before our accident happened. How does somebody's mental health history impact your assessment, or perhaps even diagnoses of concussion-like symptoms?
Oh, yeah, that's a complex file. And so a couple of pieces to that. One is, so we're often asked, if but for the accident, would they have these symptoms that they're describing and that we're seeing on objective testing? And in the cases where there's a previous history of mental health difficulties that sometimes that are in remission, that if it's remote, it may not have bearing. But if someone is actively symptomatic, and we do know that bipolar, a lot of other psychological conditions, but bipolar has cognitive impacts. So when you're actively symptomatic, either in manic or depressive phase, there are cognitive impacts to those symptoms. And in some cases, medication to treat the condition has significant cognitive side effects too. So that's important to understand their condition and the known cognitive profile or risks. And in that case, it would be helpful also to speak with collateral to have, again, as close to the pre-accident as possible, the symptom records, or how are they doing, how are they functioning. And a lot of times another cognitive bias is this good old days bias. So, everything changed from the concussion or injury, accident. I was going great before. Now everything is just complete disaster. And so that is common in folks. And so we look at that too in case of well, they may think they were doing better than they actually were, but the more data that we can get, the more we can understand, well, how were they functioning? But again, whether it's remote or active, psychological health conditions can be risk factors for delayed or sometimes incomplete, but mostly delayed recovery from concussion. So on those files, you want to make sure you have kind of early access to intervention to support their recovery as much as possible. Then you can mitigate quite usually.
This might be one of the files. I don't think there's a phone call though, so it's going to be tough to disentangle. Certainly, just the question alone. The
Yeah, and for you.
oh, it should be all right. The to wrap up, what sort of advice would you give to insurance and litigation professionals to help us better engage with you and to defend the sort of personal injury claims we're talking about today, at least from a psychological perspective?
Um, I think in most cases when defense counsel has had some questions about the file, but they may have had a plaintiff set of experts or neuropsych expert that says these symptoms are legitimate, but there's something that just doesn't pass the smell test for counsel. I've had phone calls where I've been asked to review the file to see, well, was this neuropsychological assessment done to the kind of highest standard, or are there flaws in that? Or if there isn't any objective testing, to talk about, well, would objective testing be helpful in this case? So if you're wondering, ask, and sometimes we can review some of the file or review an expert report and weigh in on whether or not it would be helpful to have more objective testing or some objective testing. But oftentimes, if there hasn't been any, occupational therapists can add some effort testing to some of their assessments, and neurologists or physiatrists or other medical professions will also comment on non-organic findings. If you're seeing some red flags on the file, we can be a resource, at least just even chat about the file, or do a file review, or do a full assessment if you think that would be helpful.
So there are levels to how you can engage with us and help build our defense here. In effect, what I'm understanding is you can either, review the file, assess, and figure out whether testing is necessary or whether you can distinguish, reports that are on file.
Yeah, that's commonly what we're asked to comment on what is the quality of the assessment work that's been done to date, and or are we is this a lot of self-report and something just doesn't add up in your expertise?
A problem sort of smelling on the file I was talking about is, I find that the test that's on file, the neuropsychological assessment, that's a mouthful. That exists on file. It seems it doesn't engage with this plaintiff's extensive mental health history in a very in really any way. That to me reeks of a problem.
Right. Yeah.
What does it strike you as?
Yeah, that's a really interesting point that if I'm doing file review, that's often something that's quite not uncommon actually is, and that has the appearance of bias actually in a plaintiff assessment is that pre-injury factors that would be, in my opinion, quite relevant are under-identified or under-interpreted as relevant in either understanding the test data, in understanding someone's recovery, or understanding just their overall symptom presentation. So it is actually how common it would be, but I have seen a number of files where I thought I've missed a page or five because there's just no discussion. And then the history taking is quite cursory. And so that's really, I think, where neuropsychologists can shine is where we can understand these pre-injury factors and put together the story to understand this correctly with all of these complexities.
It does seem like you have your work cut out for you there. But looking at the time, I just want to thank you very much, Dr. Lanting, for coming in today and sharing your insights with us. If there's any questions in the chat, I don't see any from here.
There's no questions in the chat, but we do have another couple of minutes, and so if you want to slide a last-minute question in, you're welcome. But otherwise, in the meantime, perhaps how do people get a hold of you to latch on to your expertise?
I've been primarily, at least since I've moved to Alberta, I get referrals through Viewpoint or there's another IME company, but usually Viewpoint can set something up too. You can contact me directly if you have a question or if you're wanting to just discuss a file. But most of the time, if you're wanting to do a file review or assessment, Viewpoint would be the best first point of contact, but I can let you know what my contact information is for direct contact, maybe in a follow-up or
Sure.
chat.
Yeah.
Thank you, Dr. Lanting, and thank you for your time, and thank you all today for joining us and tuning in. You can all expect an email following this the end of this session requesting your CIP number so that you can get your credit certificate for attending today. And Blaise, thank you so much for setting this up, and Dr. Lanting for joining us today.
Yeah, thank you very much for this opportunity to both of you, Brownlee, and to Viewpoint for assisting with this.
It was a fun chat. Thank you for making the time.
Thank you very much.